All right, so good afternoon, everybody. Welcome to our Tuesday Multi-Modality Imaging Conference. I am tasked today to teach you all a little bit about CT scanning. And so this is kind of an outline of my talk today. I'll tell you a little bit about basics of the CT scanner. We'll get into a little bit about how we need to optimize the CT scanner specifically to do cardiac imaging, and then a little bit about specifically how we acquire images with the CT scanner and some of the terminology you'd frequently hear us use if you were to rotate through the lab. So I'm going to get going because, as usual, I always have way more slides than I need, and I'm always guilty of that. So let's talk a little bit about chest x-rays, right? So chest x-ray is a simple 2D projection of the attenuation of x-ray. And as you all well know, it's a great tool to tell you a little bit about your patient, but it can be very difficult to determine spatial relationships with it because, you know, whatever is in the chest is compressed into a 2D plane. So we kind of get about this by using a lateral, right? A two-view chest x-ray. And what the lateral does, it gives you now an idea a little bit better of what the spatial relationships of the organs are in the chest. And so this second view becomes very, very helpful to you. And you can kind of think of it like this image over here. You know, if you were to look at this lady who's holding a pineapple and you were to look at her from, you know, the AP direction, if you were just to look at her when she's looking at you, you would never know she was holding a pineapple. Whereas if you looked at her from the side, from where her arm is extended, you would see the pineapple, but you wouldn't see her hand. So this is why why it's so helpful to have more projections, because it really helps you with spatial relationships, and it really helps you to recreate or create what the actual image, what the actual structure is. So you can imagine that if two views were helpful, what if we had an unlimited number of views? And really that's the basics of a CT scanner. It's just the systematic collection and representation of projection data. And this projection data is almost done, you know, at 360 around the patient. And so this is kind of, you know, what a CT scanner is. Again, its only purpose is to provide you with transmission measurements through the patient at multiple positions and views. And if you take a look at the right-hand side of the screen, it takes almost 1,000 different projection angles. So that's how we can get very, very robust localization of anatomy using a CAT scan. And so when you look at a CAT scan, you know, you can think of it like a loaf of bread. And each of the axial slice images that you're seeing are actually looking through the loaf of the bread at that particular slice. You can appreciate the different anatomy. All right? You have a 2D representation of a 3D structure. So let's talk a little bit about the hardware itself. So that's kind of what we're going to be doing, is we're going to be taking a lot of different views of the structure that we want to image. And how do we do that? Well, just like what you've heard, if you remember back to the nuclear talk, you know, the nuclear talks, you had the radiation source in the body, and the X-ray, the radiation would leave the patient and be detected on the outside. CT works the other way. You have an X-ray tube that generates radiation. The radiation transverses through the patient, and the degree of attenuation of that signal is then collected by a detector that's on the opposite side. So you have an X-ray tube, you have something called a collimator, and you have these detectors that are you know, on the other side of the patient. And we'll talk a little bit about, you know, the different, these different things. Collimators, you must have remembered from Dr. Mamarian's talk, very important in nuclear cardiology. They're equally important with CT. And really what they help you to do is they help you to shape the beam that's created, this radiation beam that's being generated by this X-ray tube. The collimator helps shapes it. This is just a simple sample X-ray tube I've shown. This is no different than what's also seen in the cath labs. And then the detectors that are used on the other side are these, these solid state detectors that you've heard about, like our new nuclear cameras. These are also cadmium, tungsten detectors, where they, directly take the X-ray radiation, detect it, and are able to convert it directly to an electrical signal.
Can you please speak up? We're having a little trouble hearing you.
Yeah. The room or you? You
Just
guys?
the room in general.
Okay.
The mic you have is for.
Okay. All right. So what exactly are we measuring, right? What is this X-ray goes through this patient's chest? What exactly are we measuring? Well, it's called something called the Hounsfield units, or it's another word for it is the average linear attenuation coefficient. And really what you're measuring is the degree to which the X-ray is reduced by the material that's between the tube and the detector. So this X-ray goes through the, let's say, the human body, and the amount that you are able to detect reflects how much attenuation that signal received. And that the different varied objects will have different degrees of attenuation. And this is just kind of an example, so each pixel, with this technique is given a corresponding Hounsfield units. This is a grayscale. And of course, these numbers all correspond to a grayscale, and individually they don't mean anything. But as you gradually put all these these different shades of gray together, you're able to create a very nice image of the patient. What are some of the different Hounsfield units? Water is our baseline Hounsfield unit of 0. This is this is a Hounsfield unit is all tissue and blood are all right around there. Air is very a very negative Hounsfield unit, so between -200 to -1000. Fat is in between, usually between 0 and -100. Whereas something that's more positive, such as bone can be about 300 to 500, whereas metal is very, attenuates the signal a lot, and you get, Hounsfield units of close to 1,000. So, these values that you get for different tissues are actually very specific. Now, because, yeah, I'll leave it at that. The other thing you need to know is once you have acquired these, this data, these collection of Hounsfield units, the computer then does something very similar to what's done in nuclear cardiology. You have to recreate the image with the data you've collected, and we do this through a process called filtered back projection. Dr. Mamarian probably showed you some slides on that, and basically you project the data back to recreate the original image. And this is an exact same process that's done in nuclear cardiology. With newer techniques with CT, of course, similar to nuclear cardiology, we also have a technique called iterative reconstruction. And I think, the more I try to understand this, you can think of it, we had some lectures about last week about machine learning. And I think this is kind of that, where the computers make an assumption of what the image should look like, and based on the data it's getting, it continues to correct itself until it produces the final image. So there's two classic ways to reproduce the image: filtered back projection and iterative reconstruction. Just some terms you may hear, but they are terms to show you how images are reconstructed once the data is obtained. So believe it or not, if you just look at the years here, this technique is not that old. Probably 3/4 of the fellows here, or most of the people here in this room were, not born yet, but in the grand scale of things, this were in the 70s when all of this came to head, and and in 1979 is when the two major founders won the Nobel Prize for this technique, and so and really we all know how it's revolutionized how we practice medicine. So let's now specifically, we kind of, a little bit of understanding or terminology about the basics of the hardware, but how can we use this hardware now to, capture cardiac CT as you've seen it? Well, cardiac CT gives you a lot of different dilemmas which are not necessarily the case with other body imaging. Why is that? Well, number one, you have very complex anatomy and it's small. These blood vessels can be 2 to 3 millimeters. And so you need a technique that has a very high spatial resolution. Second thing is, the heart is the only structure in the body that's continuing to move. And it can be affected not only by its own movement, but also by respiration with the heart, chest opening, expanding and contracting. So you have a lot of motion in the chest and you have to be able to take pictures of a very small object that's moving. So this can be, quite technically demanding. So how do you get around doing that? Well, these are some of the things that I'm going to be talking about in the next several slides, but I will go to show you how CT addresses each of these issues. Number one, it's a technique that, of all the non-invasive techniques, has the highest spatial resolution. We'll talk about that. It has now, with some of our newest Siemens flash CTs, a very high temporal resolution, down to 75 milliseconds. It can provide very fast coverage because we can practically image the whole heart in one cardiac cycle. You need to be able to we need to know when systole and diastole occur, because remember, the heart is moving continuously in motion. So we need to be able to gate our images to an EKG. And so that was a very important development. And then we'll talk a little bit about contrast resolution. Because although CT's Hounsfield units are very specific, there's a lot of overlap. And so how do we create better signal contrast for some of our vascular structures? So how do we get around, one of the issues is, the heart is continuously in motion. This is just a nice graph showing you the velocities of the right coronary artery, but that tends to be the most mobile coronary artery. And what you'll note is that there's two particular phases in the cardiac cycle where the velocities are the lowest. And I've tagged them there in the yellow screen. That you can, two places where it's the motion of the heart is the slowest is in end systole and in end diastole. It kind of makes sense, right? There's a moment in time where the heart is completely contracted before it starts to relax, where you would expect it to be still. And then finally, when it's relaxed, there's just a moment in time before the atrial kick happens, right? So those are two general phases where the coronary velocity. So we try to do, because the heart is moving the least, we try our best to do all our imaging in that period of time. And the way we recognize those period of times, of course, are by gating it to the EKG. So you have to have a good EKG, because you have to know when systole occurs and you have to know when diastole is to capture these two periods of time. So this is just an example. Those of y'all who rotate through the lab have seen this. These are one patient who did not have EKG gating, and the RCA is completely uninterpretable. Whereas here you'd use EKG gating, you optimize the study to capture the images at a predefined time point, usually when the heart is the most still, around the 70% phase of the RR interval, and you get a pristine artery. So that's where, so not only now that we've identified when the heart is the most still, we also have to have a technique that has what we call temporal resolution. It has to have what the shutter speed, or the ability to acquire one image, has to be fast enough to capture your image in that short period of time when the heart is the most still. And that's temporal resolution, the ability to capture an image or to freeze cardiac motion during the time when the heart is in standstill. And so we'll discuss how we improve temporal resolution with cardiac CT. So before we do that, I hope these two pictures will share with you why we sometimes are often adamant about beta blocking our patients. And the images on the right hand show you that in general, if you look at systole and diastole, in general, despite whatever the heart rate is, systole is generally, the time frame for systole is generally preserved. So systole occurs during the same time interval no matter what your heart rate is. Kind of makes sense. However, diastole is significantly compromised as the heart rate increases. So if you want to take an image in diastole when the coronaries are the most still, and your temporal resolution of your scanner is, a certain amount, you want to make sure you have enough time in diastole that your camera can take a picture during that time. And so how do we prolong diastole? We prolong diastole by giving beta blockers. We slow the heart rate down. As we slow the heart rate down, your diastolic filling time or diastolic length of your diastolic phase increases. So why we stress so much on being able to give these patients beta blockers. And this is just another graph showing you a couple of things. Number one, there are two still phases of the heart. If you look at image quality, excellent image quality being there in the circle. One, best image quality is obtained at end systole and mid diastole, and that as your heart rate increases, and of course this is data for the 64 slice scanner, your image quality worsens. So importance of having, at least if you're using a 64 slice scanner, a good heart rate. But I would say it's good to have a nice low heart rate even if you have some of the dual source scanners that we do. How do we figure out temporal resolution? Well, one thing you have to know is in order for the CT scanner to create an image, it turns out you only need half a turn, because it can, most of the body is symmetrical, and I think it assumes, so it just needs data of half a rotation. So now most of these scanners, this is, imagine a scanner without, once you take the covering off, this is generating almost 28 Gs of forces. So it's tremendous amount of speed and pressure, to spin around the patient. And if on average, most of these machines are able to, because they're limited by the G forces that are created of this very heavy thing spinning, it takes about 330 milliseconds to go around 360 degrees. So to generate an image, if you only have to go around 180, that's about 165 milliseconds. So that's about the temporal resolution of our 64 slice scanners, about 165 milliseconds. That means it acquires an image in 165 milliseconds. There are other ways we can do things to improve our temporal resolution with 64 slice scanners. The top image just shows you where different portions of the heart are taken in different portions of different heartbeats. But the bottom slice shows you what you can do, something very similar. This is called multi-segment reconstruction. And this is very similar to what CMR does. And basically, in order to create one image, you use information from multiple heartbeats. So what that allows you to do is you're sampling a shorter period of time during two separate heartbeats, combining the information and effectively reducing your temporal resolution. So this can be used with a 64 slice CT. But really, and this is just an example of that, partial reconstruction with 64 slice CT. You use multi-segment reconstruction. You see the blurriness in the image because the heart here was in motion. It wasn't gated. With multi-segment, where you dropping the temporal resolution by half, now you can freeze the image motion of the ascending aorta. Really, the biggest improvement in temporal resolution is because we can't turn the gantry any faster because of these G-forces. Why not have two heads, right? So now, if I have to create an image by going 180 degrees, if I had two heads, now each one only has to turn quarter, because one will move a quarter, 90 degrees, and that simultaneously the other one will move the opposite 90 degrees, and you'll get your 180 degrees of data. So really, the next innovation was having two heads on the scanner. So this would now take that 165 milliseconds that you had with the 64 slice, cut that another half, and now you're down to a temporal resolution of 83 milliseconds. What does that mean for your patient? Well, now I can take a picture really fast. So I may not need all that diastolic time, right? So now my heart rate's can be a little bit higher. I don't need to beta block as much. I can take a picture like this, so I have less radiation I can give. and I need a heck of a lot more contrast because I'm imaging so fast. So a lot of benefits by having a very fast temporal resolution. And it turns out that the temporal resolution with our dual source Siemens, the next generation dual sources, is down to actually 75 milliseconds. And I'm not sure how they play around with these numbers, but that's what is quoted. What about spatial resolution? Well, spatial resolution similar to CT, CMR, there's two types of spatial resolutions. There's the X and Y, or in-plane spatial resolution, and you should know by CT that is completely out of your control. That is determined by the product that you buy, and in general, all the different vendors, in general, about 0.5 millimeters, 0.5 millimeters. Z-axis resolution varies between the different vendors. The Z-axis, or the through-plane resolution, in general is determined by the collimator width. Remember, we had said there was a collimator that, by the detector width. And that, in general, can be, depending on the scanner you buy, anywhere between 0.5 and 0.625 millimeters. So in general, most of the time, our spatial resolution in the X, Y, and Z planes are identical. Spatial resolution, of course, can be determined by other things, pixel size, and we'll talk a little bit about that, patient motion. But in general, if you're looking at the XY, it's all determined by the characteristics of the particular scanner. So this is just, again, now talking a little bit about how the vendors all differ a little bit in their Z-axis resolution or their through-plane resolution. In general, they're all between 0.5 and 0.625. But they create these different detector geometries in order to achieve different things. And we can talk a little bit about that. Unfortunately, it turns out is we really cannot get better Z-axis resolution than 0.5 millimeters. And that is only because those detectors are really not as good yet, unfortunately, and because every time they try to decrease the size of that detector, there's more noise in the image, and more radiation is required. So at least in the technologies right now, we're kind of capped at around 0.5 to 0.625. There are some tricks that these vendors use to try to improve spatial resolution. This is something called a Z-flying focal spot, where it actually, the detector is able to rapidly move a little bit in the Z-axis, left and right, and gain extra information. And by gaining extra information, you improve your spatial resolution a little bit. Matrix size is important to talk about. This is important with any technique. When you present when you display your data, you want to be able to give the same pixel size as the spatial resolution that you collected your data with. So in general, this is, your pixel size is determined by your field of view divided by your matrix size. Your matrix size is fixed. It's usually 512 by 512, at least with CT. And so you want to use a 250 millimeter field of view, and you want to make sure that the heart is within that 250 millimeter field of view. And that gives you then a pixel size that's displayed of about 0.5 millimeters. Well, why is it important to have spatial resolution that's the same in the X, Y, and Z dimensions? And this is very unique to CT, is the fact that with this technique is such a high spatial resolution technique. It's high spatial resolution technique in all three dimensions. And what that allows you to do is then you can, what we say, move freely within whatever plane that you want, and you'll have no degradation of image quality. You'll have no loss of spatial resolution, because the spatial resolution is the same in all three directions. So it becomes very important for us. You've heard the word swivel or MPRs. You're able to do those things without the image, any image blurring, because the spatial resolution is high in all three dimensions. Spatial resolution is actually very important and results in some of the common artifacts that you are used to seeing. One of the artifacts that you've heard is that if you have a poor spatial resolution, you may have something called partial volume effect. Partial volume effect is, if you take a look at this, this picture that I have there. You know, all the black is, let's say, a Hounsfield unit of 10, and the white is 0. If your spatial resolution is bigger than the boxes of that grid, well, you're going to have some pixels there that have a little bit of white and a little bit of black. And the computer won't know which one to assign, so it gives it something in between. And it gives it something. So in general, it'll give you a value less than what is normally seen in that pixel. And so when you come out with the image, you kind of get a little bit of blurring or loss in image quality, because you are assigning values or intensities to pixels that are not truly what were represented. So you kind of lose, you know, the clarity, the crispness, the borders, the edges, you know, which can be very important for us. Another simpler way to think about it is it's also, this whole partial voluming is also responsible for, or this poor spatial resolution is responsible for this blooming artifact that we see with calcium. Those of you all have rotated through the lab, you know calcium is a major Achilles heel for us, because once that calcium is there, it appears, we know it appears bigger on the image than what it is in real life. And it appears bigger is because we don't have spatial resolution small enough to clearly separate what's the lumen of the artery from the calcium. So because our spatial resolution is poorer, on a pixel that has both things, it assigns it a value that's higher than what it should be, and you get this thing that looks like a calcium extending out into the lumen of the artery. So that's a direct resolution of what can you do about this. You know, we have some filters that we apply, but the real way to get around this is to get techniques that have better spatial resolution. Spatial resolution is equally important. Why, you know, till this day I can't understand why some of our techs don't like to give nitroglycerin. We're talking about arteries that are 1 to 2 millimeters, 3 millimeters. You know, we want to plump these up, make them juicy and big. So I have the ability to see them clearly and differentiate them from the surrounding structures. And this is just an example of a patient, same patient. You can see the right coronary artery definitely looks bigger when you give nitrates to that patient. This is just a slide going over, in summary, some of the new techniques with spatial, different techniques with spatial and temporal resolution. Main things I want to point out, all the spatial resolutions are stuck with CT around 0.5, 0.6. Temporal resolution is improving with our bigger scanners such as the dual source scanners. Best techniques yet are, of course, invasive coronary angiography, where spatial resolution is 0.2 and temporal resolution is 20 milliseconds. So that's still, this invasive method is still the best test when it comes to spatial and temporal resolution. Okay, next issue with CT is, coverage. We want a technique that's fast. We don't want to be like the CMR guys, sit there all day, 1 hour scanning patients. We want now, we're in 10 seconds, right? So how can we do that? Well, one is, how many detectors do you have? And I think the next image will, this will kind of tell you. If you have a detector of a certain length, you'll have to go a certain amount of times around the patient. Whereas if you have a detector shown here, in this picture here, where is longer, where you're able to acquire more information, now you only have to go around the patient, you only have to go around the patient a lot less compared to when your detector was a lot smaller, because you're able to cover a lot more ground and you're able to acquire all the information that you need. So now the trend is increase the number of detectors. And this is just a graphic trend of time, of different, detector rows different vendors have used. And you can see the one that stands out is the Toshiba, which is your 320 detector, you can see that it covers a distance of almost 16 centimeters. So you can imagine with that Toshiba scanner, you can acquire the entire heart in one heartbeat because it sees the entire heart in one heartbeat. Whereas with the other ones, they're slightly smaller in their coverage, so you may have to spin around a couple of times or acquire information over a few more heartbeats. And this is just a nice, hopefully this will kind of drive home the point. With our 4-slice scanners, we could only acquire a certain amount of information, so you gotta really spin that camera a couple of times around the chest before you acquire the entire heart. Whereas as you increase the number of detectors, another word for detectors is slice, as you increase the number of slices, you can see you're able to acquire greater volume of information. And finally, with a 320 slice scanner, in one image acquisition, it captures the entire heart. And cardiology can have very important implications. This helps us with speed. This helps us with radiation doses. This helps us with contrast, because the faster you take the image, the less you need of all of those. And then what about atrial fibrillation? That's a pain in everyone. It's difficult for everyone. But the faster your scanner is, the better off. If you can acquire an image over one RR interval, you're a lot better off with AFib, where you can't predict what the other RR interval would look like. And this is just a slide going over, just how different vendors have approached it in how they set up. There's pros and cons to everything. So contrast resolution, you should know in general that if you just did a CAT scan without giving contrast, we really don't have the best tissue contrast. CMR is far superior in tissue characterization. That improves a lot more, at least for vascular structures, when you give iodine or iodinated contrast agents. And there you really, really improve the photoelectric effect with radiation significantly improves, and you get a markedly increased differentiation from background tissue. And this is just a graph. I know y'all may not be able to, I'll explain this as best as I can. In general, our CT scanners are using X-rays that have energies between this. And if you look, these are just a graph showing you how well at those energies, how well bone, muscle, and iodine attenuate at those energies. And what you'll notice is that if you look at muscle and bone, which are these two guys, they really are at 1. There's really not much difference. But with iodinated contrast agents, you get a markedly different attenuation profile, because it is much more, it attenuates much more with contrast. Okay, and then finally I threw in a slide there, just showing you the different techniques and comparing their spatial contrast and temporal resolution. I'll just point out CT, of the non-invasive techniques, nothing beats CT for spatial resolution, nothing beats CMR for contrast resolution, and when it comes to temporal resolution, nothing beats echo. So everybody has their own strengths. Now, let's get into a little bit about the more common terms that you hear is how to scan these patients. And this is kind of, I hope will, we can, y'all have any questions, please let me know. I know this can be a lot of information fast. So one of the first ways we acquire information is what we call retrospective EKG gating. So I'm going to describe it in my own way. What basically happens here, the table is continuously moving, okay? And what you're doing is you are doing a helical acquisition. So the table is continuously moving, and the CT scanner is continuously going around your patient, acquiring information. It acquires information throughout the cardiac cycle, so throughout systole and diastole. And then retrospectively, that's where the word retrospective, once you've acquired all this data, you can go to any particular phase of the cardiac cycle and reconstruct that image. So if I want to see just systole, I can go in systole and reconstruct those images. If I want to see diastole, I can go specifically to that data set and reconstruct that image. Most important things you need to know here is that radiation is on throughout the cardiac cycle because you're acquiring throughout the cardiac cycle. So, and this is just an example. Data was collected throughout the cardiac cycle. I retrospectively go back and say, now I only want to look at data in the 60% phase or the 70% phase or the 80% phase, and you can recreate those images of whatever phase you want. One thing to kind of understand as we talk about this is the concept of pitch. With retrospective gating, pitch is really the speed of the table feed divided by the width of the collimation. And the best way to understand it is just to look at this graph. When we do retrospective gating, we want to acquire, we often you don't never want to miss data. So a pitch greater than 1 is where you have gaps in your data. And this is an example of that, or this picture right here is an example of that, where your table is maybe moving faster than the width of your collimators. And so as it turns, it's actually missing data. In CT, we always want to oversample. So we want pitches that are less than 1, at least with retrospective gating. And what that means is that we may make a few extra cycles around the patient, but we're acquiring all the data that we need to be able to reconstruct images in systole and diastole without loss of data. Because remember, loss of data for us is very unforgiving. We don't answer the clinical question. We gave them contrast and we gave them radiation. So we purposely with retrospective gating have a low pitch to oversample data and to make sure we have all the data we need to reconstruct. A pitch of 1 is perfect table movement with a perfect matched by perfect collimator width. So no image is no data is ever duplicated, but no data is ever lost either. Whereas a pitch of greater than 1 is you have loss of data because your table may be moving faster than the width of your collimator. With retrospective gating, of course, because you're acquiring, one of the strengths is, and why we use it, is because you're acquiring data throughout the cardiac cycle. It allows you to calculate, it allows you to look at data and throughout the cardiac cycle. So in other words, we can use that data to look at ejection fractions, ventricular functions of both the left and the right. We can look at motion with the valves. We can look at motion of masses. Now, the next step that's nice, but we really are radiating these patients a lot. All that data we're getting, and we did that for a very long time. Someone said, hey, you know what? The arteries are the most still in diastole. I want those pictures to be crisp. I don't mind if my systolic images are a little bit less blurry. And this was the concept of retrospective gating with dose modulation, where your tube current is maximal where you want your most best images, here in mid-diastole, and the tube current falls where you may not necessarily want information you're particularly not interested in, for example, systole. So those images will be markedly deteriorated. And so this is an example of that. You can adjust the parameters, you can choose the MAs that you want to deliver, and etc. But if you look at the two images of the heart, one is at end diastole, tube current is optimized, you have nice crisp images, whereas if you look at the systolic images, the heart doesn't look as clear as it does like in diastole. And the only reason is tube current came down in order to save radiation. And it turns out this technique saves about 25% of the radiation dose. So it's a very valuable technique. We still use it. So retrospective gating, we talked about the top screen here. You can see radiation dose is delivered throughout the cardiac cycle. Next came retrospective gating with dose modulation, where they said, just turn down the dose in data that we don't care of. We don't care too much about systole because the coronaries aren't that still then. Ramp it up during diastole. Then someone said, you know what? let's take it even a step further. Let's reduce the radiation dose even further. Let's just drop all the systolic. Let's just not image at all in systole. And so this is what is known as prospective scanning, where you apply no radiation dose during phases of the cardiac cycle you're not interested in imaging. And when you get to the most still portion of the heart in diastole, tube current goes up and you acquire those images. So this was a very, it turns out is a very robust technique to reduce radiation, and it reduces it almost by 75%. Prospective triggering is also known as step and shoot. The table dynamics move a little bit differently. Instead of the table continuously moving, what you're doing here is you're taking slices per heartbeat. You're taking a slice, and then all those slices are eventually stitched together to create an image. And so this is kind of what happens is, here you can see the tube current goes up in diastole. You acquire one slab of data. In the next heartbeat, the table moves to the next location. You image that location and create an image. The table then moves. You again then take an image at the next location. Those images are all then merged together to create a single image. Benefits of this technique, of course, are its low radiation. And this is just an example of prospective gating. If I didn't make it clear, slab 1 is acquired in one heartbeat, slab 2 is acquired in second heartbeat, and et cetera, and the images are put together to create a complete image. So and this new Toshiba scanner, the 320 slice, because it has such large volume of coverage, one of its strengths is that you can do this prospective axial scan, and you can do a prospective scan in one heartbeat and get the entire heart. So you don't need that stitching example that I showed you here. Here, with this scanner, its coverage is so large that in one heartbeat, you acquire the entire heart. And of course, again, that translates into less radiation, less contrast. And it could be a potential benefit in atrial fibrillation. All these techniques, our newer scanners now have, techniques called arrhythmia rejection. This is no different than what we see in CMR. You prescribe a certain R to R interval where you say, yes, this R to R interval is good data, and anything that falls outside of that R to R interval, the computer assumes there was an arrhythmia, skips that beats, skips that data, and goes to the next heartbeat to acquire data. So all of these scanners can now do this, and it helps you obviously get images that are not corrupted by arrhythmias. But if a patient has a bunch of PVCs, PACs, you should know your scan times will be longer. You may need some extra contrast because there are a lot of heartbeats that are not going to be imaged at. Studies have shown there's really, in image quality, there's no difference in image quality between prospective and retrospective scans, and here are two examples. However, the dose of the radiation, again, is significantly reduced with prospective scanning, almost close to 75%. And this is just a review slide showing you, what are the benefits and differences of axial versus helical scanning. Axial, another word for step and shoot, another word for prospective scanning. Basically, very little radiation. And the benefit of the helical scan is, of course, is that you have all data throughout the cardiac cycle. So you can make cine movies of ejection fractions. It does at the cost of higher radiation. It's also more forgiving to arrhythmias because you can reconstruct in whatever time phase you want. So now I threw this slide in just to kind of transition us back into thinking about the dual source CT scanner. Remember that this is a scanner that has two heads. So they're perpendicular. The heads are 90 degrees to each other. So theoretically, each one head only has to move a quarter of a cycle, and with the data between both tube A and tube B, you can create an image. So a temporal resolution with these scanners can be as fast as low as 75 milliseconds. And why I mention this is because now you can acquire an image over such a short such a short time period, 75 milliseconds. Wouldn't it be great if you could somehow do a helical scan where the patient is continuously moving through the scanner, yet still acquire images prospectively off the EKG? And really that is what these scanners are able to do. And this is known as what we do day to day in the lab, is what we call prospective EKG triggered helical mode. And basic concept is now that the temporal resolution is, the image acquisition is so fast that I can acquire, the table can move in a step and shoot manner. No, I'm sorry, time out. The table can move in a helical manner. The patient can be continuously moving through the scanner, and I can acquire images only in the particular phase of the cardiac cycle that I'm interested in. And why that's so amazing is because now I can image rapidly. You'll see images I'll show you of trauma patients, where they can go through the scanner like that. And you have the radiation benefits of being able to do things prospectively. So with the ability, because of dual sources temporal resolution, you now have the ability to meld the best of two worlds. Okay? And this is what do you call it? Dual source. Yeah, and so this is what we do. You can either the patient is going in, the scanner is moving, and prospectively you're acquiring data whenever you want. That's one way you can image. Or the other way you can image is something called, if you have proper patient characteristics, proper heart rate, no arrhythmias, you can do what you may have heard, the flash mode. We talk about the flash mode. What is the flash mode? The flash mode is where you acquire all the data in one heartbeat. So just like that 360 Toshiba I showed you acquired in one heartbeat, we can use our dual source CT to acquire all the data in one heartbeat. And you can imagine then radiation is very, very low. And this is just an example of an image that was acquired over one heartbeat. You can see the image quality is unchanged. You can see the radiation doses depending on what parameters we put to scan. We can regularly today scan certain patients, ideal patients, with less than 1 millisieverts of radiation. So I can acquire the entire image on one heartbeat. And if you look at the bottom image, you can see that the table is moving in a manner, in a helical manner. It's continuously moving. And I hope y'all saw it because it doesn't want to play for me right now. But it's a very, the pitch is 3.4. The table speed is exceptionally rapid. And this is very important for, you can imagine, imaging in the ER, where these patients come in with trauma, have life-threatening injuries. Bam, you put them in the scanner, the images are out before the patient practically, goes through the scanner. So again, all the benefits of a temporal resolution where you can acquire, your shutter speed is so fast that you can acquire images so quickly. This is just a little bit about the dual source CT scanners that we have upstairs, and that you have, hopefully will have the opportunity to come and work with us. We're acquiring another one of these, so it's important to know a little bit about it. Not much to say other than, it's dual-headed, it's very rapid, it's, and has a temporal resolution of about 75 milliseconds. Okay, this is just a graph showing you, the different radiation doses of different techniques, and I'm just emphasizing now that if you look at a retrospective CT scan, which is right here, that was classically 10 to 15 millisieverts. Those were the old days. Now with dual source CT, where it can be potentially in the right patient down to less than 1 millisievert worth of radiation. So very, very powerful techniques. I hope you guys know everything about CT now. Any questions?
have a general question outside of CT. For the last table you gave, what is the safe amount of a receiver you can get for a year, for example?
Well, if you're a patient, there is no number. Healthcare workers are 5 millisieverts. Am I right about that?
Yeah.
5 millisieverts, yeah. So healthcare, that you wear that badge about 5 millisieverts. Patients, there's no. In general, because there is this risk of, there's these theories of radiation. Most people agree that the more radiation you receive, it is a cumulative effect. There's immediate effects where you can have a risk of skin burn and all of that, and then there's a long-term risk of cancer. And so in general, we follow the principle of ALARA, or as low as reasonably tolerated, where you give the lowest dose, but still you answer the clinical question. And so in general, because now, we know so much about radiation, we know the risks of radiation, we know, we have young patients coming to us, female patients coming to us. We really, especially those patients who often need frequent imaging, which is frequently the case, we really make a conscientious effort to reduce radiation doses. And that's another talk. There's a lot of tricks beyond what I showed you. We can adjust MAs, we can adjust KVPs, we can, meaning we can adjust how much energy we're delivering to a patient. But yeah, it's a big deal in the CT world now, and a lot of people believe we'll come to the day where we'll actually report these in our reports, how much you were delivered.
What scanner do you have here, Dr. Nabi?
The dual source. Siemens dual source. Easy crowd, huh? That's it.